And Summers Hogg, welcome to the podcast, More Health, Less Healthcare. And you're the Director of Health Research at the Christensen Institute, and you write a really terrific Substack column called Healing Healthcare. I can't think of a better title for a Substack article. And your focus is on, I like this, innovation that actually works, emphasis on actually works. And your contention is that, better health really rests with better innovation. And it really sounds like that's what Atrium Health and Advocate Health set out to do. And I want to thank you for all the work you put in. It's a terrific case study and really adds to the health equity case studies handbook. I think we can learn from failures as much as we can learn from market successes. But first, okay, how did you get into this line of business? And what is the Christensen Institute? It deals with complex issues. You have models, you have theories. What is it about? What does it bring? It's unique. What does it bring to the healthcare market?
Great. Well, first, thank you so much for having me today, Peter. It's awesome to be here to chat with you. And so I'll start with what's the Christensen Institute? So the Christensen Institute is a nonprofit, nonpartisan think tank dedicated to improving the world through innovation. And we leverage Harvard Business School professor Clay Christensen's business theories, and we apply them to the social sector. So our research focuses on three main areas: healthcare, education, and global prosperity. And we use Clay's theories to tackle seemingly intractable problems across these three areas in order to improve the world and make it a better place for the future. Now, folks probably know Clay Christensen best for his theory of disruptive innovation, but he has many others that we leverage too, such as jobs to be done, business model theory, the theory of modularity. Maybe some of those we'll chat about today.
Well, certainly the business model, we can start with that, but what attracted you to the Institute? What's your background?
Yeah, that's a great question. So I started my career actually in strategy consulting. I worked for a firm called Oliver Wyman, and in my time there, I worked in their health and life sciences sector, actually on the payer side of healthcare. So I focused on developing value-based care strategies for large payers. And this was at the time of the patient-centered medical home in the early days of the ACO. So payers were trying to figure out what should they do in the face of these new regulations. After a couple of years, I realized I didn't love living in airports and in hotels, so I went back to graduate school. And I went to UNC Chapel Hill, where I got my Master's of Science in Public Health in Health Policy and Management. And I stayed in North Carolina for quite a while and ended up in Charlotte, where I worked for Atrium Health across their innovation engine and corporate strategy functions. Then on the provider side, while I was in the innovation engine, I was developing value-based care models, this time for a provider, specifically around primary care and behavioral health and a couple other disease-specific models. And then, go ahead.
So you used to work at Atrium, which is part of the case study. Okay, go on. This is great.
Yes, indeed. So I spent my last year and a half working for the Chief Strategy and Transformation Officer at Atrium Health, developing our long-term enterprise strategy and serving as his chief of staff. And it was during my time in that position that this opportunity opened up at the Christensen Institute. And in my days in the innovation engine at Atrium Health, I had the opportunity to go to Harvard Business School and learn from Clay and his teaching team about all of his theories, and then try to put it into practice at Atrium. So it was really just a dream job that this opened up. And so about 4 years ago, I jumped ship, and I've been here ever since.
Well, the right ship to jump onto. When I look on this case study, and it's a complicated case study, and you have two established companies, traditional companies, both sponsor what could be very promising initiatives. One is a transformation approach, one is an incremental. I'm not making a value judgment on either. Both are valid.
Great.
But when I put on my recovering consultant hat, it seems that both traditional companies are really wedded to fee-for-service, a sickness care model, yet they're spinning out very different kinds of services, very different kinds of metrics, or it should be different kinds of metrics. That you're going from a sickness care model to a wellness and health prevention model or illness prevention model. And at the same time, both the startups are absolutely dependent on parent company key resources. And the two parent companies are still anchored in the metrics of budget cycles and quarterly earnings and profitability. And you have this other initiative where it's going in basically the opposite direction. It's going to where the market seems to be moving towards more value-based care and certainly more emphasis on wellness. And when I look at this and I look back on the lack of support from top to bottom that the two parent companies had that you're dependent on for metrics, accountability, and organizational resources, I really have to really wonder, what were they thinking? And if you have two competing value sets, two competing value systems, and the metrics that go with it, it's not a recipe for success. So I'm kind of curious that with your background and the kind of business models that you've been articulating with the Christensen Institute, how do you look upon, was it just a question of, certainly a question of leadership failure, but it's also a lack of situational awareness right across the board, which I found very, very striking. So what kind of business theory and models with the Christensen way of thinking, what could have come to bear?
Oh, that's a big question, Peter. So let me try and break it down into a couple pieces. So first, I would say, and this was something that Clay Christensen identified in his work, The Innovator's Dilemma, which really
Mhm.
looked at why is it that leaders fail to invest in innovations that could disrupt their existing business model, basically until it's too late. And one of the things he pointed out that I think is really key is the leaders don't fail because they're bad leaders. They actually fail because they're really good leaders at doing what has led to success in the past.
Mhm.
They've they continue to execute on what has brought them success, and they miss seeing this thing that appears to be a non-event that comes in at the bottom of the market, but then it rapidly moves up market and it displaces them. So I want to be careful not to blame the leaders. It's not that they're bad leaders. They're
Yeah,
actually good at doing what's brought them success in the past.
right, right.
Um, so that's what I would say first. And then I think the second point is one of the theories we use at the Institute is business model theory. And in that, Clay laid out that a business model is made up of four interlocking parts that, when taken together, create and deliver value. And those four parts are the value proposition. So that's the promise or the promises that a healthcare organization makes to its consumers and customers, its resources, the assets it uses to deliver that value proposition. Third are its processes, how the organization carries out its work. And then fourth are the profit formula or priorities. So how the organization covers its costs and allocates its resources and makes sure that it has a sustainable margin. Now, when new innovations come to bear that threaten existing business models, the business model that has hardened over time and proven successful will fight back. The resources in it, the leaders in it will want to crush any innovation that threatens the profit formula or threatens the priorities or offers a fundamentally different value proposition that would threaten the existing organization's ability to do what it has done so well for so long. So, where leaders often struggle with executing innovation is they try to bring up a potentially disruptive innovation within their established business model. Organizations who don't do that, who instead succeed by developing a potential disruption, do it through what we call an autonomous business unit. So they build this potential disruption in a totally separate business unit that has a different business model. It has different resources, it has different processes, it has a different profit formula, and it's allowed to have different priorities or measures of success. So that's not to say all innovation should be off in a skunk's work separate department, but if the innovation has disruptive potential to the core organization, it has to be separated if you want it
Mhm.
to succeed.
Of all the words that you use, the one that jumped out for me was profit formula.
Uh-huh.
Is there any way to work with a dissimilar profit formula?
Within the same organization?
Yeah.
No. It's why value-based, it's one of the reasons value-based care hasn't really taken off, right? Because we can't just try to pay people differently without providing the support for the rest of the business model to operate differently and hope that the outcomes will change.
All right. So you have good people have been successful being managers and
Mhm.
they're profitable and they're going to have a profit formula that they're going to apply to a new enterprise that has a very different business model. Help me understand where's the disconnect here of the leadership group that tries to impose a similar profit formula on an enterprise that has different values, different processes, and hopefully different outcomes.
Yes. So that's why it has to be separated. And there's this saying that goes along with business model theory that nobody but the CEO can be in charge of this autonomous business unit. So if you're going to set up a potentially disruptive innovation outside of your core organization, it has to have a direct line to the CEO, not the CSO, not the COO, the CEO, because only the CEO can give the leader of this autonomous unit the ability to do things differently. Only the CEO can say, you can have a different profit formula. You can have different priorities. You can get paid differently. You can come up with something as silly as you can have different job codes for your resources. Because in large established organizations, the processes and the rigidity help the organization function the way it reliably brings in margin, but those act as inhibitors and barriers to potentially disruptive innovations.
All right, let's say these two new startups had the support, always the tacit support of the CEO that they reported to. Where would the funding come from?
CEO has to grant it. And that's not to say only the CEO has to grant it. If we look at the Advocate Aurora Enterprises model, this was actually a really impressive approach where it did function as an autonomous business unit. There was a direct line to the CEO, but actually the agreement was amongst all of the C-suite in order to continue funding this entity
And did
because all
that
the members
happen?
of this, I'm sorry.
Did that happen?
hmm It did in its
Okay, okay.
existence, as long as it existed. It no longer exists today because actually Atrium Health and Advocate Aurora combined, and now they're
All right.
Advocate Health. And as part of that combination, Advocate Aurora Enterprises was eliminated. But when Advocate Aurora was a standalone entity, before the combination with Atrium Health, they had this autonomous business unit called Advocate Aurora Enterprises.
Okay.
And it reported to the CEO. The entire C-suite agreed to allocate separate funding to it because they believed in the future that it was building for. So they were actually a great example of how to create this separate unit outside of the mothership, outside of the core organization, and allow it to function with different priorities, a different way of getting paid, and a different set of capabilities, so resources and processes.
Okay, so you're hinting at innovation that actually works. What's your model of innovation and how does that comport to what you basically observed within these two companies?
When you say your model of innovation, I'm not exactly sure what you mean. Say a little bit more.
Well, both are attempting to disrupt the market,
hmm
and they had different approaches and different goals and objectives, probably, but they failed to really disrupt the market. So, what is it about an innovation model that sets out to disrupt the business? Basically, it sets out to disrupt the market and, in fact, doesn't.
Got it. Okay. So for
And what
that, we
happened?
think about like how do you assess a disruptive in or an innovation's disruptive potential?
Yeah,
One of the
yeah.
things we talk about at the Institute is that it's not that disruptive innovations are better than sustaining innovations. Disruptive innovation is a theory of competitive response. And if you can understand whether or not an innovation has disruptive potential, you as a leader can better understand how the market will react and how the competition is likely to play out. So, we actually developed a 6-question test to help innovators, entrepreneurs, and leaders assess the disruptive potential of an innovation. And
Walk us through it.
yeah, I was going to say, for folks watching this on YouTube, you can see the visual. For those who are just listening to the audio, I'll walk you through the 6 questions. So the first question is, does it target non-consumers or people who are overserved by an incumbent's existing offering in the market? And this is because disruptive innovations don't start by going after incumbents' best customers. They start at the basement door. They start with the customers who are the low end, so they're low margin, or they start with people who are left out of existing markets, so non-consumers, people who aren't buying existing solutions because they can't afford them. So the first question is, does this new innovation target non-consumers or those at the low end of the market? The second one, the second question, is the offering not as good as incumbents' existing offerings as judged by historical measures of performance? So we often say that disruptive innovations feel not as good as the prevailing solution. So to use a healthcare example, a minute clinic might seem not as good as going to your primary care doctor because one, it's in the closet of a CVS. You're seeing a nurse practitioner and not a primary care doctor. And the list of things that they can treat at Minute Clinic is a lot shorter than the list of things that can be treated at your primary care doctor.
Right.
So when you think about disruptive potential, one of the things you want to assess is, does this new innovation seem not as good as prevailing solutions? The third question is the innovation simpler to use, more convenient, or more affordable than the incumbent's existing offerings? The fourth, does the offering have a technology enabler that can carry it up market and allow it to improve? And this one is important not because technology enablers in and of themselves are disruptive. They're not. Technologies aren't disruptive. Business models are disruptive. Business models disrupt business models. But Clay noted early on when he identified the theory of disruptive innovation that there was often a technology enabler that allowed these innovators to outpace incumbents. The fifth question is the technology paired with a business model innovation that allows it to be sustainable. And that's because, to my point, business models disrupt business models. And then six, are existing providers motivated to ignore the new innovation and not feel threatened at the outset? And this is important back to what I said in reference to question one, which is if new innovators enter the market and they go after incumbents' best customers, the incumbent's going to fight back. They're not just going to sit around and let their best customers get taken away. But if innovators enter the market and they serve really low margin customers or customers who aren't consuming the incumbent solution, they're much more likely to be ignored. So those are our 6 questions.
Well, the one that jumps out to me is it's tech is not a disruptor, it's an enabler. And if tech is basically paired with an innovative business model, and it gets back to, I guess, is your point number 5, that's the winning combination. And it seems to me that so much of the marketing hype in the market today is all about different forms of AI as being very, very disruptive. How do you see that playing out?
That's a great question. So AI in and of itself might be disruptive in the sense that it causes chaos
Yeah,
in the business place or chaos in the way we execute our daily lives. But generative AI in and of itself is not a disruptive innovation. It has to be wrapped in a business model and it has to be relative to something. Whenever people ask me the question, which I get a lot, is fill in the blank disruptive. The first thing I always ask back is relative to what? Because
right.
disruption is relative. If business models are disrupting business models, I have to understand what are you comparing it to? So I don't think the question is generative AI disruptive is an especially great question because it's asking about a technology and it's not providing a comparator. A different question that would be easier to analyze would be something like, is open evidence disruptive relative to up to date?
Would you
Right?
say a little bit about what that is?
Yeah, so open
Okay.
evidence, if folks aren't familiar, is a basically chat GPT for doctors,
Yeah.
but it doesn't hallucinate and it pulls evidence and it provides citations for all of its answers from the latest evidence base. So, Open Evidence has partnered with JAMA, New England Journal of Medicine, and other
Right.
highly reputable journals in order to quickly become physicians' trusted AI point of care solution.
When I read about the future of AI, which none of us know where it's going, what do you see the most positive aspects in terms of business models and how to enable more innovation in business models? Are there particular areas of applied AI that you think probably hold the most promise when paired with different kind of business models?
Yes. I do think that while I don't think that open evidence necessarily checks a lot of the disruptive innovation boxes, I think it'll succeed in the market because it taps into an underserved desire for progress or what we call a job to be done that many physicians
Right.
have, and it does the job very well. Um, so that I think is one great application, which is providing physicians with the latest knowledge that is incredibly hard to keep up with because
Right.
the medical literature doubles every 5 years, and that's hard to keep up with as a physician. I would say it's impossible to keep up with. So providing a way to get the latest evidence at the point of care is really impeccable. I think another application that will be incredibly useful is in our transformation from paper charts to EHRs. There's a lot of unuseful data that's just
Right.
trapped in EHRs that's really hard to get out. That's not a human scale problem. That's a technology scale problem. And I think it's something that generative AI could do quite well, not only to enable better care, but actually as a data source for research.
If we're talking about patient-centered care and whole person care, where do you see the best of the AI intentionality applied to that?
Hmm.
I understand how you can do throughput and workflow improvement and efficiencies. I'm not convinced yet that it's pro-patient as much as it is perhaps pro-clinician.
I see. One place that I think it could be useful, and I want to be sure to caveat this, is in mental health. And so hear me out on why.
Okay.
Because I think there are a lot of ways that it could be used and is being used that are worsening mental health. But I think there are specific use cases where it can be used beneficially. And over the summer, Dartmouth researchers published their work with an AI chatbot they had developed called Therabot. And this was overseen by mental health clinicians. I can't remember if they were psychologists or psychiatrists, but they oversaw people participating in the study where they either had depression or anxiety, or I believe eating disorders, and they were interacting with this AI therapist, which the
A
Dartmouth
bot.
clinicians called Therabot.
Okay.
But it was overseen by the clinicians. So when the Therabot gave inaccurate information, or when the participant in the study said something that needed a human to engage with, like let's say they mentioned suicidality or something, the clinicians were there providing oversight. Now, in the study, the Therabot allowed these clinicians to serve many more people than they could have served alone. And so it served as an augmentation to existing clinical workforce, not necessarily as a replacement. And the outcomes were impressive. They helped people reduce anxiety, reduce depression, and reduce eating disorders. And when there were instances where human interaction was needed, those clinicians provided it. So I see it being a patient-centered, and yes, this is also clinician-centered, benefit when it's augmentation, not replacement to
Yeah. Yeah.
humans. I
Yeah.
think it's hard to solve the workforce problem in healthcare without some artificial intelligence. And I
Mhm.
think the challenge will be leveraging it in the most effective and ethical ways.
Well, you sound downright optimistic.
I mean, in some instances, we could talk a lot longer about the places where
Yeah.
I'm not optimistic,
Well,
but
we'll wrap it up here on an optimistic note. Um, but thank you again. This is terrific. Just your way of thinking and the models that are created. I mean, that's essentially what we need to make innovation actually work. And I see an absence of critical thinking and situational awareness from the top to the bottom. And I think your work is absolutely terrific. And your podcast is top of my reading every single week or two. But I want to
well,
thank you
thank
very
you.
much. And your contribution to the book was terrific. And keep up the good work.
Thank you so much, Peter. It's always fun to chat with you.
Thank you.